right atrium. So just like the right ventricle, the right atrium is extremely important, right? And the function of the right atrium is assisting filling the right ventricle. As you know, blood travels from the superior vena cava and the inferior vena cava into the right atrium. So it sort of functions as a reservoir to store the blood, and it assists in the filling of the right ventricle. You can see the right atrium in the apical four-chamber view, uh, and of course in the subcostal view as well. But if you're going to plane, when we do planimetry to look at things like the area, it's best to do it in the four-chamber view. But you can also look at the right atrium very well in the subcostal view. All right. Um, Very important. You should try and, when you're doing a routine study, try and do planimetry of the right atrium because you can pick up right atrial enlargement. Uh, and we talk about an area less than 18 centimeters squared. So anything greater than 18 centimeters squared, the right atrium is enlarged. Okay. Um, and this is how it's done. So it is very important to know how it's done. Don't just do any little tracing. So you have to trace across the tricuspid plane, straight line, and then you come down the border, the interatrial septal border, then you plane the walls of the right atrium. Okay. Um, and the computer will give you the area and say it should be less than 18 centimeters squared. If it's greater than 18 centimeters squared, then it's enlarged. You also have to remember the values for the right ventricle, and we went over those um, in the last lecture. Right. So when we plane the right atrium, there is a minor axis or a minor dimension and a major dimension. And so this would be your major dimension right there, and then the minor is straight across. Okay, so if the minor dimension is more than 4.4, then it suggests right atrial enlargement as well. And if the major is more than 5.3, it suggests right atrial enlargement. So just look at it again. So if this is more than 4.4, the minor dimension, that's right atrial enlargement. Then the major, if it's more than 5.3. Okay, so you have to measure it time and time every time so that these numbers sort of stick with you. You can't just read it. Well, okay, well, it's the same thing we are saying. For enlargement, the normal should be less than, so the area should be less than, so if it's more than 18, it's enlarged. So the minor dimension should be less than 4.4. If it's more than 4.4, it's enlarged. So it's the same thing we're saying. But all right. So the we can do the hemodynamics, and we have done this in our hemodynamic session, but we're going to go over it again. So you can use the tricuspid regurgitation um, to to assess pulmonary pressures and right ventricular systolic pressures. And this should be a part of your routine study again. So you need to be extremely familiar with this. So using the fact that if you have tricuspid regurgitation, you're getting blood flowing from the right ventricle across the tricuspid valve into the right atrium. And the reason why that is occurring is because there is a pressure difference between the right ventricle and the right atrium. So if the pressure in the right ventricle is greater than the pressure in the right atrium, blood is going to go from the right ventricle to the right atrium. Okay? And when you get your TR envelope, okay? Your TR envelope, there's a time on the horizontal axis and a velocity on the vertical axis, and we get our envelope. So if you remember the modified Bernoulli equation, gradient is equal to 4v squared, where v is the velocity, okay? So you can get the gradient across a tricuspid valve. But as I mentioned before, that gradient is equal to the systolic pressure in the RV minus the pressure in the RA, right atrium, right? So if you just rearrange that equation, the pressure or the systolic pressure in the RV is equal to the gradient plus the right atrial pressure. Now, this is how you assess the right atrial pressure. You'll see, when you read, you'll see all sort of stuff, but I'll prefer you to stick with the AC criteria, the American Society of Echo criteria. And that states that we give the right atrial pressure. The right atrial pressure can be normal or it may be elevated. A normal right atrial pressure is about 3. Okay. If it's a little elevated, then it's 8. If it's grossly elevated, then it's 15 or more. Okay. So what they do, they measure the IVC, the inferior vena cava. Remember, the inferior vena cava empties into the right atrium, and when you do your subcostal view, you can see that. You should measure it just before the hepatic vein enters the IVC. If it's less than 2.1 centimeters, or if you get more than 50% collapse in inspiration, then that's normal. Okay? So normal is if it's less than 2.1 centimeters, and if you get more than 50% collapse, because the inferior vena cava collapse with inspiration, but it should be more than 50% collapse. So if that's the situation, then the right atrial pressure is 3. And then we take it to the next extreme. If it's more than 2.1 centimeters, and if you get less than 50% collapse with inspiration, then the right atrial pressure is 15 or more. Okay? So more than 2.1 and less than 50% collapse with inspiration, right atrial pressure is 15 or more. And anything that's in between is 8. So if it's not normal and it's not to the extreme, then it's 8. So the numbers you need to remember is 3, 8, and 15. 3 is normal, 8 is in between, and then 15 is the extreme. Okay? So more than 2.1 and less than 50% collapse. You had 15. So you'll get the right you'll get the right ventricular systolic pressure. The right ventricular systolic pressure is the same thing as the pulmonary artery systolic pressure unless there's obstruction at the right ventricular flow tract. If there's no obstruction there, then the pressures are the same. The right ventricular systolic pressure and the pulmonary artery systolic pressure is the same. Okay. So most commonly, it is estimated by utilizing the inferior vena cava diameter from the subcostal view and the presence of inspiratory collapse. Okay, so it's difficult to see this with your two-dimensional echo. So what I strongly advise you to do is do a M mode across the IVC, and you can see clearly if it's collapsing. So practice that so you can see it. Okay, so do the M mode. So you're going to measure the IVC, and it should be at the end. When you measure, it should be at end expiration. Okay, and again, just proximal to the junction with the hepatic vein, where the hepatic vein comes in. IVC collapse with respiration, so-called sniff, should be measured. So again, 3, 8, 15. Normal is if it's less, the measurement, if it's less than 2.1 centimeter, and if you get more than 50% inspiratory collapse. 15, if it's more than 2.1, you get less than 50% collapse, okay? So this is how it's done. So this is our IVC right here. This is the hepatic vein entering into the IVC. So you're going to measure just proximal to it, okay? So this is the measurement, and as I mentioned before, it's best to use the M mode to see if there is a inspiratory collapse. Okay, and then this table just went over. So the normal is less than or equal to 2.1. Okay, and then you're going to get more than 50% collapse with sniff or inspiratory collapse. That's normal. So you're going to have an average of 3. And then the extreme, if it's more than 2.1 centimeter, less than 50% inspiratory collapse, okay? And then if you look at the tricuspid EE prime greater than 6, diastolic flow predominance in the hepatic vein. So all these things are 15. All right, so you have to know these because they're going to test you on it, and when you're doing your report, you have to put it in. All right. So again, the right ventricular systolic pressure is the same thing as the pulmonary artery systolic pressure, unless there is obstruction at the right ventricular flow tract. I did show you guys how to measure the pulmonary artery diastolic pressure. Okay, in our hemodynamic session. Remember, you need to get PI. You need to have pulmonic insufficiency, and you want the end diastolic velocity. So it's 4v squared, using the v as the end diastolic velocity, and you're going to add the right atrial pressure to that, and that's the pulmonary artery diastolic pressure. So again, or pulmonary artery systolic pressure is equal to the right ventricular systolic pressure unless there's an obstruction at the pulmonic valve or right ventricular flow tract. And this is going to become very important when you talk about patients with pulmonic stenosis. Remember, with second years, we just went over tetralogy of Fallot. It's extremely important in those patients, and you're going to see those patients. Because those patients, even though they're repaired and you see them as adults, some of them will have what we call branch pulmonary artery stenosis. So either of the left or the right. So remember, you have the pulmonary trunk, it divides into a left and a right. Some of those patients will have branch pulmonary stenosis, and the gradient across the pulmonary valve will be high. So you have to know how to. And if the stenosis is very significant, then those patients may have to go back to surgery. So we're going to go over this when we do our Thursday webinars with Tetralogy Fellow. We're going to look at all of this because it's important. When you see these patients come to the echo lab, you have to recognize what's going on. You have to get the necessary measurements because you can't bring them back. Okay, so you have to know what you're doing. Also, when we do our Thursday webinars, you're gonna see a lot of these patients. If you're doing adult echo, then when you see them, they already had their repair. As a baby, so you have to have an idea of what kind of repair they have, and there are some common repairs. They will have shunts, and most of them will have definitive repair. So we'll go over the type of shunts that some of these patients had, and then what can happen to the shunt, because some of these shunts may be obstructed. So you have to know how to assess it. So we'll go over that. But I said all that because the right ventricular systolic pressure is only equal to the pulmonary artery systolic pressure if there is no obstruction at the right ventricular flow tract or the pulmonary artery. If there is no obstruction, then the right ventricular systolic pressure is the same thing in the pulmonary artery systolic pressure. And we went over why you get TR, because there's a pressure difference, and there is a gradient. The gradient is equal to the pressure difference in the right ventricle minus the pressure in the right atrium. That's the gradient. And the modified Bernoulli equation, the gradient is 4v squared, where v is the velocity. All right, so this just, we went over this, but you have to understand this. You cannot guess it. You cannot memorize it, because when you go in the exam, you're not going to remember it. So you have to understand it. Gradient is always a pressure difference from the high pressure to the low pressure. That's the only way you can get a gradient. Okay, so high pressure minus the low pressure, that's a gradient. And from our Doppler, we know that gradient is 4v squared. So if the pressure difference in tricuspid regurgitation is from the right ventricle to the right atrium, then it's the right ventricular pressure minus the right atrial pressure that's equal to the gradient. So the right ventricular pressure is equal to the gradient plus the right atrial pressure. And we went over how to assess right atrial pressure. So you have to understand that as well. Okay, 3, 8, 15, and 2.1 is the measurement, and 50%. The normal IVC is supposed to collapse more than 50% with inspiration, or the sniff test, they might ask you one of those. Okay. So again, when you're doing any Doppler, multiple windows, because you want to get the ultrasound beam as parallel to flow as possible. You want to get that angle theta close to 0. Cosine of 0 is 1. Okay, so you apical 4-chamber, whatever. But one of the best view to get maximum TR is the right ventricular inflow view. Okay, but you're going to get it from the short axis view at the level of the aorta, where you have the tricuspid valve right there. You're going to get 4-chamber view. You can get subcostal view. But you'll get your highest velocity in a lot of situations in the RV inflow view. All right. So this is just short axis at the level of the aorta, tricuspid regurgitation. Okay, just quickly reviewing the Doppler, your transducer is right there. Okay, with tricuspid regurgitation, blood is now flowing from the RV across the tricuspid valve into the right atrium. It's moving away from the transducer, ends it's below the baseline, and then this is the velocity. Okay, so that gradient, the gradient is 4v squared, and the computer give you right there. So the velocity is 2.89, and square the velocity and times 4, that's 33.5. So that's a gradient. To get the right ventricular systolic pressure, then you have to have the right atrial pressure. Again, multiple windows, because you want the maximum velocity. Okay, so pulmonary artery diastolic pressure, you need PI, pulmonic insufficiency. You need PI, okay? remember you and using the same hemodynamic principle. You know, what is PI? What is pulmonic insufficiency? It is blood flowing from the main pulmonary trunk across the pulmonic valve into the right ventricular flow tract in diastole. In diastole, okay? In systole, blood flow from the right ventricular flow tract across the pulmonic valve into the pulmonary trunk. That's fine. But when you have PI in diastole, the valve is supposed to be competent, but in a lot of situations, the valve is incompetent. So in diastole, instead of the valve closing shut, there's a gap, and you have blood flowing from the main pulmonary trunk across the pulmonary valve into the right ventricular flow tract. It's only going to do that if there is a gradient. And that gradient, again, is the diastolic pressure in the pulmonary trunk, because the blood is moving in the opposite direction. So the diastolic pressure in the pulmonary trunk have to be greater than the pressure in the right ventricular flow tract. So it is the diastolic pressure in the pulmonary trunk minus the diastolic pressure in the right ventricle. That's a gradient. And that's equal, the gradient is equal to 4v squared. But the velocity is the end diastolic velocity of the PI. Okay? So now to get the, if we want to get the PA, if we want to get the PA diastolic pressure, so if we want to get the PA diastolic pressure, then it's equal to the gradient plus the right atrial pressure. Everybody follow that? All right. So in diastole, blood is flowing from the main pulmonary trunk across the pulmonary valve into the right ventricular flow tract. That is why it's pulmonic insufficiency, because the normal in systole, blood, the pulmonary valve opens and blood flow from the right ventricular flow tract across the pulmonary valve into the main pulmonary trunk. That's supposed to happen. Then in diastole, the pulmonary valve is supposed to close shut. But if it's incompetent or for whatever reason, then blood is going to flow past the pulmonary valve back into the right ventricular outflow tract, and that's what we call pulmonic insufficiency. It's only going to do that if the pressure in the diastolic pressure in the main pulmonary trunk is greater than the pressure in the right ventricular flow tract, right? So that gradient, that pressure difference is equal to the diastolic pressure in the main pulmonary trunk minus the diastolic pressure in the right ventricle, right? That's the gradient, because blood is flowing backwards. That's a gradient. That gradient is 4v squared, but the velocity we're going to use is the end diastolic velocity. So the PA pressure, PA diastolic pressure, now we're talking about diastolic pressure. We already know how to get the PA systolic pressure. The PA diastolic pressure is equal to the gradient plus the RV diastolic pressure. But the RV diastolic pressure is the same thing as right atrial pressure. Okay. All right. So, and this is what it looks like. So you have to have PI. Okay. So if you remember your PI jet, again, quick Doppler review. Your transducer is right there. You see a two-dimensional image, short axis at the level of the aorta. Your cursor is right there. Your main pulmonary trunk is right there. This is your right ventricular flow tract. Blood is flowing from the pulmonary trunk across the pulmonary valve into the right ventricular flow tract. It's moving towards the transducer and sits above the baseline. This is the early velocity, and this is the end velocity. So that's the end velocity you need. Okay, 4v squared plus, this is the velocity plus the right atrial pressure to get the PA diastolic pressure. Okay, so this is just a review. We did this before in hemodynamics. So that is the end diastolic velocity. And this is our early pulmonic regurgitation velocity. All right, now we come to mean pressures. Even though we report a systolic and a diastolic pressure, if you're going to define, most definition of pulmonary hypertension have to do with mean PA pressure. And it's very important, we should be reporting mean PA pressure. And I'm going to give you two methods to do it. Well, three methods. A very good method is when you have tricuspid regurgitation. If you plane the envelope, the computer will give you a mean pressure. It will give you a peak pressure, and it will also give you a mean pressure. If you use that mean pressure, mean gradient, sorry. If you use that mean gradient and add the right atrial pressure to it, that's mean PA pressure. Okay? Another way of doing it is to estimate it using the formula that the mean PA pressure is equal to 1/3 the systolic plus 2/3 the diastolic pressure. So I already show you how to get the systolic pressure, right? And I'll show you how to get the diastolic pressure. So if you just use 1/3 systolic, multiplied by 1/3, and 2/3 the diastolic, that will give you the mean pressure. Okay? Or what you can do is, remember when you have your PR, we have or early velocity and late velocity. If you use the early velocity for V squared plus right atrial pressure, it give you the mean PA pressure. So the three methods that I gave you is plane the TR envelope, and the computer give you a mean gradient, and you just add the right atrial pressure. Or you can 1/3 systolic, because you already get your systolic, plus 2/3 diastolic pressure. Or you can use the early PR velocity Doppler signal. And of course, you always have to have the right atrial pressure. It should be close. Yeah, it should be very close. So again, so we have our PI. So you're going to use the early velocity. If you use the late velocity, then you're going to get the PA diastolic pressure. If you use the early, you get the mean PA pressure. The definition, if you read most textbooks, when they talk about pulmonary hypertension, they usually refer to the mean PA pressure. Okay, even though when you look at a lot of the echo reports, they're using the pulmonary arterial systolic pressure to grade pulmonary hypertension. We're going to get away from that, because pulmonary hypertension is better defined with the mean PA pressure, and it's not as simple as that. So we're getting away from that, because a lot of people don't know what it means. Okay. Also, we can use, and we'll get to that, but we can use the right ventricular flow tract envelope. If we use the acceleration time, that will also give us an indication of the mean PA pressure. We'll go over that. All right, so let's move on to the tricuspid valve. So we're looking at everything right side. We look at the right ventricle already, so you have to know it, all the stuff that we went over on right ventricle. We look at the right atrium, size, the function, and then how to assess pressures. Now we're going to move on to the tricuspid valve. And again, the tricuspid valve is situated between the right atrium and the right ventricle. It consists of 3 leaflets, and you should be familiar how to label them. Okay, you have a anterior leaflet, you have a posterior leaflet, and a septal leaflet. Remember, one of the best view to see the posterior leaflet is in our RV inflow view. You have to remember that, and you have to know where it's located. You're going to get that in the exam. I'm pretty sure they're like that. So they're gonna give it to you. All right. So you have to know how to label the leaflets, 3 leaflets. All right. So the velocities and the pressures on the right side usually is less than the velocity and the pressures on the left side. So the peak velocity across the tricuspid valve in diastole, because blood is going to flow across the tricuspid valve in diastole. The peak velocity is usually less than 0.7 meters per second. Remember, when we talk about the left side, it's usually about 1 meter per second. On the right side, the velocities and the pressures are usually less. Not only that, you tend to get respiratory variation. So if they give you something in the exam, and they will also give you lower velocities. But if you see variation in the height, it's more than likely on the right side. So you get respiratory variation. So if you see a TR envelope and an MR envelope, the MR envelope will be consistent. Almost all the peak velocities will be the same. Whereas when you look at TR, the peak velocity is going to be varying because of respiratory variation. Okay? So again, the tricuspid valve is somewhat complex. There is you have coordinated tendonae, more than 2 papillary muscles, which distinguish from the left side. You have a fibrous annulus. The thing about if you remember what we said, the geometry of the right ventricle is very complex. It has a very complex geometry. Okay, so the geometry is very complex. All right. So you have to know everything about the tricuspid valve. Okay, it's a question.
Yeah, before it says 3 or more papillary.
Yeah, 3 or more. That's supposed to be 3 or more. Yeah.
Okay.
All right. So all right. So diseases affecting the tricuspid valve. And similar to the mitral valve, you can get tricuspid stenosis. The valve doesn't open. So rheumatic fever can give you that, as well as, we uh, we talk about carcinoid syndrome. That can give you a stenotic tricuspid valve. So tricuspid stenosis, rheumatic fever, carcinoid. Carcinoid is a substance which is produced by a tumor. Tumor usually is found in the GI tract, the small intestine or something like that. And then when it metastasizes to the liver, it travels to the liver. When it travels to the liver, it produces these chemicals which tend to give you a waxy infiltration of mainly the right side of the heart. So the right side, especially the valves, become sort of waxed. So if you think in terms of Kangol wax, I mean, it sort of hold it in place. So you'll get tricuspid stenosis and regurgitation. You can also get pulmonic stenosis and regurgitation, mainly the right side. So that's what carcinoid syndrome is, usually a tumor that produces. So you can also get tumor of the tricuspid valve, vegetation from infective endocarditis, valve damage from pacemaker, uh, aneurysm of the sinus of Valsalva, prostatic obstruction. You can have prostatic tricuspid valve. So these are some of the disease state that can affect the tricuspid valve, similar to the mitral valve. What are some of the signs and symptoms of tricuspid stenosis? Now we're moving into tricuspid stenosis. So the tricuspid valve is not opening properly. So you just think again, blood is going to back up into the right atrium. So it's going to back up into the IVC. It's going to make the liver large. And if the liver is large, you're going to get what we call ascites because fluid is going to fill the abdominal cavity. Then not only that, the legs are going to be enlarged because, I mean, everything is backing up. Okay, so the legs are going to be, and you're going to have edema, ascites, the liver is enlarged, the jugular veins are going to be engorged. So we can just work it out. So you get fluttering, discomfort in the neck because of the engorgement, fatigue, because the cardiac output is going to be reduced. So once the cardiac output is reduced, the patient is going to feel fatigue and weak. Cold skins, right upper quadrant abdominal discomfort from the liver being enlarged. So they'll tell you that they have pain right there, and then when you palpate, you feel that the liver is enlarged, and then it will be tender. Okay, jugular pulsation from the blood building up into the jugular vein, and then you get what we call a presystolic murmur at the left sternal border, the fourth space. So it's a diastolic murmur, okay? Because remember, blood flow across the tricuspid valve in diastole. So because it didn't open all the way, it's stenotic. So you're going to hear that swishing sound when the blood is flowing across the valve. So it's a diastole. The tricuspid valve opens in diastole. So you're going to hear a sound in diastole, and it's going to make a noise because the valve is not opening properly. And that's what we call the diastolic murmur or presystolic murmur. Okay? I mean, that's what it is. Everything on the right side increase with inspiration. So just one thing to remember. And everything on the left side increase with expiration. So that same murmur, when you listen to it, and you tell the patient take a deep breath in, it's going to get louder. Okay? So all murmurs on the right side increase with inspiration. All murmurs on the left side increase with expiration. All right, so that's tricuspid stenosis. And the most common cause, I mean, it's rare. I mean, you can get it from rheumatic fever, but one of the most common causes is carcinoid. Patient with that tumor, they get carcinoid. All right, so again, this is our apical four-chamber view. And so apical four-chamber view, okay? We can work out which is the right side. As I say, the heart does not come labeled, and especially when they're doing an exam, it's not going to be labeled. So you can see that this is the right side. Okay, the tricuspid valve is a little lower in the ventricle than the mitral valve. It's a diastolic frame. You can probably just look at the ECG. It's the markers at the onset of the QRS. And you can see the tricuspid valve is a bit thickened. So once you know what your normal tricuspid valve is supposed to look like, that's why you need to look at a lot of normal. You can see that this is thickened, it's not opening fully. There's something going on in the mitral valve too, but but the right atrium is also enlarged, and probably the right ventricle to some extent. Okay. This is Doppler across the tricuspid valve. Okay, You see there's also TR, you can see that. This TR, it's triangular, peak early. So that's one sign of severe TR, okay? And then when we look at this flow across the tricuspid valve, this is definitely stenotic. This, we supposed to get our ENA fuse. It's a continuous wave Doppler. This is what stenosis look like. Just using the same principle from the mitral stenosis. Okay. But what you're going to do, you're going to plane this to get the gradient. So there's shouldn't be any significant gradient across the tricuspid valve. It's supposed to, when the tricuspid valve opens, supposed to allow blood to freely flow from the right atrium into the right ventricle. All right. So as again, this patient of carcinoid, because with acquired tricuspid stenosis, carcinoid is one of the most common. All right. Um, the the elevated peak diastolic velocity is 1.6, but what you want to get is you want to get the gradient. Okay. Remember, with mitral, we talk about 5 and 10. Okay. So anything less than 5 is mild. Anything greater than 10, mean gradient now. Anything greater than 10 is severe. So because the right side, the pressures are usually less. So you're not, it's going to be lower pressures. Okay. All right. So again, so this is TR, TS. Okay. All right. And the mean gradient here is 9. Okay. So we're going to look at the criteria to determine severity, but this is severe, okay? Because remember, the gradient on the pressures on the right side is much lower. So, and again, when you're doing anything on the right side, it should be a modified view to look at the right side properly. So it's a RV focused view, okay? And just looking at the valve, you can see it's thickened. There's doming, and there's marked enlargement of the right atrium and to some extent the right ventricle. Um, okay. You can also do the pressure half time, but it's best to just plane it to get the gradient. Okay. And then these are the recommendations or the okay. So for the mean gradient, mean pressure gradients, it should be well, not for this for severe. This is for severe tricuspid stenosis. The mean gradient is going to be more than 5, so it's different from mitral stenosis. So mitral stenosis has to be greater than 10, but pressures on the right side tend to be less. So for significant tricuspid stenosis or severe tricuspid stenosis, we talk about a mean gradient greater or equal to 5. Okay, if you look at the pressure half time, it's going to be more than greater than equal to 190 milliseconds. And then if you do the valve area by the continuity equation, it will be less than or equal to 1 centimeter squared. Okay, so you can use your inflow time integral. So remember what you do, you just plane it and give it the time integral, the velocity time integral. So if it's more than 60, that's also suggestive of significant tricuspid stenosis. But the things that you really have to remember is the gradient greater than equal to 5 millimeters mercury, or valve area less than equal to 1 centimeter squared. Okay. Um, we're going to leave TR for the next session. But any question? Okay, so